Hello, good afternoon, everyone. Thank you for joining us. My name is Kate Livesey, and I'm a Senior Policy Advisor here at the King's Fund. Really pleased to welcome you to today's online event, where we'll be discussing efforts to tackle antimicrobial resistance in the UK with our panel of experts. I'd also like to thank our sponsor for this event, the Association of British Pharmaceutical Industry, the ABPI. Now, we've got a great panel of speakers with us this afternoon, representing a range of different perspectives, and I will get each of them to introduce themselves properly in a moment. First, though, I'll just take a minute or two to set out how the online event will work. We've checked before coming online, and I think we've got something like over 1,000 people signed up for this session. So we're really looking forward to your contributions later in the discussion as well. We're running today's event live, and we'll kick off with a panel discussion, and then that will be followed by some audience Q&A. So we'd like to invite you to submit questions for that Q&A via the Slido box, which should appear to the right of the video for all of you watching. As well as submitting questions, you can upvote the other questions being asked by other people, and we'll aim to answer the most popular ones that are coming through. We'll also be putting out some poll questions to the audience during the session, and these will flash up for you at different points. So please do take part. You can follow the conversation as well on Twitter or X using hashtag KFOnline. Now the general housekeeping is out of the way. I'll get us started with a quick reminder really of why we're here, and to help set the scene before moving over to our panel to introduce themselves. So I suspect most of the people joining are doing so because they recognise the significant threat that antimicrobial resistance poses to the health of not just our nation, but all nations globally. But for anyone who is a bit newer to the topic, a reminder that antimicrobial resistance, or AMR, as it will probably be referred to quite a bit in today's call, occurs when bacteria, viruses, fungi, parasites no longer respond to the antimicrobial medicines, which would normally be used to prevent and treat infections. And the emergence and spread of drug-resistant pathogens really threatens our ability to treat common diseases and infections, and also our ability to perform routine surgical procedures like C-sections or hip replacements. And this is why AMR has been declared one of the top 10 global public health threats by the World Health Organization, as many of you may know. So in 2019, the government published its 20-year vision for tackling AMR, as well as a 5-year action plan. We don't intend to use today's discussion to scrutinise progress against that plan, but I will just highlight some of the headlines from the government's latest surveillance report, which hopefully provide a useful backdrop for our conversation. So that report found that in 2022, which is where the latest data is, 58,224 people in England are reported to have had an antibiotic-resistant infection, which is a rise of 4% since 2021, where we know that COVID-related measures likely slowed down infections. The report also found that prescribing of antibiotics in England increased in 2022 after many years of steady decline, and all settings except dental saw more use. However, overall use has remained below pre-pandemic levels. The report found that between 2018 and 2022, there was a 1.6% reduction in the total number of antibiotic-resistant infections in England, which is against a backdrop of the government's ambition to reduce this by 10% by 2025. And then finally, perhaps one of the most concerning findings of that report, certainly illustrating some stark inequalities. Of all the bloodstream infections detected in England in 2022, the report showed that Asian or Asian British ethnic groups had almost double the proportion of antibiotic-resistant infections at 34.6% compared to white ethnic groups at 18.7%. So with that brief context for today's discussion, I'll move across to our panel and ask each of you to please introduce yourselves, including a very quick overview of your current role and your experience around this topic. So if I could ask Colette to introduce yourself first, please.
Certainly, thanks, Kate, and good afternoon, everyone. I'm Colette Goldrick, and I'm Executive Director for Corporate Affairs and Strategy at the ABPI, the Association of the British Pharmaceutical Industry. We're a trade body that represents the companies that research, develop, and bring to patients new medicines and vaccines.
Thanks, Colette. Matt, could I ask you to introduce yourself next, please?
Sure. Hi, everyone. Matt Anardikim. I'm an acute physician, so I work in a hospital. And my other job is as National Clinical Director for Infection Management, Antimicrobial Resistance Deterioration. I also lead on acute respiratory infection hubs and led on COVID oximetry.
Thank you, Matt. Louise.
Thank you. I'm Louise Sweeney. I'm a consultant microbiologist. I work in Manchester. I am a member of the British Society for Antimicrobial Chemotherapy Council. I'm the antimicrobial resistance lead for my department, and my experience is that I work in the region of England that has the second highest AMR burden in England per 100,000 population, and it is something that I deal with on a weekly basis.
Thanks very much, Louise. And Ron.
Yes, thank you. Good afternoon, everyone. My name is Ron Daniels. I am an intensive care clinician in Birmingham, and my area of Birmingham that has very high socioeconomic deprivation, very high indices of non-white ethnicity populations, and therefore we see a lot of antimicrobial resistance. I'm also Vice President of the Global Sepsis Alliance and Chief Executive of the UK Sepsis Trust, which is a charity that supports people affected by sepsis, but also delivers clinical tools, including the Sepsis 6, to clinicians across these countries and more broadly. So we have a responsibility within that charity to make sure that we promote the responsible treatment of people with sepsis, and that includes responsible approach to AMR.
Thanks very much, Ron. And thank you, everyone. Clearly a wealth of expertise and a range of different perspectives to bring to today's conversation. So I will get us started with our first question then. Given some of those headlines I sort of set out earlier and your own knowledge about kind of what progress has been made or not, really keen to hear from each of you, sorry, on whether you think we are making enough progress on antimicrobial resistance, and linked to that, have we got the right approach to tackling AMR in the UK? And if not, why not? So Colette, I'll start with you, please.
Thanks, Kate, and thanks to the King's Fund for convening this really important discussion. As you've said out already, antimicrobial resistance is not a future problem, it's here right now. And I know my esteemed clinical and academic fellow panelists will be focusing on the spheres of infection management, stewardship and diagnostics and how things are going there. But I want to talk about the stage before that, the development of effective new antimicrobials. And here, Kate, I think there is room for optimism. I think in the UK we are making progress. So one of the challenges we face with AMR is that resistant bacteria are developing faster than new antibiotics. There just aren't enough new products in the pipeline. And to put that into numbers, in 2021, there were only 43 new antimicrobials in clinical trials compared to 1,800 in new oncology treatments. And that's because, like all medicines, discovering and developing new antimicrobials carries a high cost and risk of failure. But unlike other medicines, where companies can recoup those costs through volume sold, the use of new antibiotics, of course, needs to be kept to a minimum to help reduce AMR. And as a result, medicines often sit on the shelf and don't deliver revenue for many years. And this means in practice, we have not had a new class of antibiotics since the cephalosporins in the 1980s. Now, that might sound very depressing, but right here in the UK, the government, NICE, NHS England and industry have collaborated to pilot a groundbreaking approach to try and tackle that situation. How does it work? A subscription fee is being paid for each antibiotic, irrespective of the volumes used by the NHS. And that does two things. It creates a pull incentive for companies to develop new treatments, and it also removes the need for companies to drive volume, which in turn helps ensure appropriate use. Pilots have finished, resulting in 2 new antibiotics being available to the NHS to treat AMR. And over the summer, NHS England run consultation to roll out a new permanent model, and the outcome of that consultation is expected in January. Now, there are only a few countries trying to do something like this in the world, and the model itself is a first. So I do think on this front, we are making progress here in the UK, but there are still a few caveats. We do need to see the new model that the new model is implemented quickly in all 4 UK nations, not just England. And once it is implemented, we need to monitor to see if it actually works as an incentive. If it doesn't, obviously, we need to evolve it. And finally, perhaps most importantly, the UK can't solve AMR alone. We need other countries also to be incentivising the development of new antimicrobials. And we need to see UK policymakers continuing to raise this issue on the international stage, because we simply can't afford not to. Thank you.
Thank you very much, Colette. And yeah, clearly some progress being made, and development of new antimicrobials are a really important part of a wider programme of work needed around AMR. I'm going to turn to Matt, please, to give your perspective as well on whether or not we're making enough progress, and have we got the right approach?
I think we're making some progress. I'm not sure we're making as much as we could do. And I think, like many clinicians, I feel that we are too silo-based in our approaches to both resistance and, crucially, the management of infection. There is no separation from an existential problem like resistance. And it is existential until you're faced with a patient that you actually see with a multi-drug resistant organism. It becomes something you're aware of, but not something that comes to mind first off when you're encountering a patient with suspected infection. And it's how you bring AMR concerns and strategies together with the entire infection management process that I think will deliver the most wins in our current strategy. We've hit a roadblock, I think, in terms of what we can accomplish by going down a pure AMR route. And increasingly, what we are finding actually is when you bridge the gap and actually consider the entire process of how patients developing infections can actually have those infections prevented or curtailed right at the start through a combination of great chronic disease management, but also empowerment and tips and tricks about what to look out for and what to do at the first signs of potential infection, as well as good control of chronic diseases. And then you launch into the assessment process itself and the heuristic decision-making of when we give antibiotics and how we decide someone has a suspected infection, supported by advances such as point-of-care diagnostics and investment in that field to actually support clinicians and patients do the right thing. Because it's a defensive culture we live in, where litigation doesn't often side with the side of a clinician who is well-meaning and trying to avoid antibiotic prescriptions in patients with suspected viral infections. And then underpinning all of that, we need great data that actually links the real-world experience of and embraces this condition of suspected diagnoses and suspicion. And all of this needs supported by pathways that actually fit the need. It's no use having a pathway that looks at a specific condition when you don't know what the condition is you're treating. And the grey world, this grey boundary of what we actually see in real clinical practice is the frontline reality. Patients don't come with a label attached to their forehead telling you what's wrong with them. They come with a constellation of symptoms and signs, which could be any manner of diagnoses. Therefore, our pathways have to fit that. And organizations like NICE need to focus on that greyness in order to guide best treatment options. And then finally, wrapping all of that up, we need a responsible communications and behavioral insights plan that influences both clinician and patient and societal behaviors as well, and the training and education within that will deliver us best outcomes. So your question, a short answer to your question is no, we don't have the right balance. And the only way we're going to, I think, overcome AMR is by having a more broad consensus of infection management as a whole, and bringing in people that aren't necessarily antimicrobial resistance specialists, but people that actually do the care and have the illnesses.
Thank you very much, Matt, and really appreciate you bringing in the importance of not just those who are doing the care, but those who are receiving the care into shaping what the right approach looks like. Ron, could I ask you to build on that and add your thoughts on our question around whether we're making enough progress and have we got the right approach to tackling AMR?
Yes, thank you. And building on it is exactly the right phrase, because I absolutely agree with everything Matt has said. And if I can try to sort of expand and bring some of this together, when we talk about silos and when we talk about data and we talk about the phrase Matt used, infection management. So AMR is, as has been said and is agreed, an existential crisis. And indeed, Dame Sally Davies has said, I think quite rightly and truthfully, that it's a more pressing existential crisis than climate change. Both are important, but both equally important. But antimicrobial resistance isn't what brings about the patient dying. It's infection that we can't treat as a consequence of antimicrobial resistance. So the mode of death for these patients is an untreatable infection, and most commonly, the development of sepsis. And when we talk about silos, we have separate departments, separate statutory bodies looking at antimicrobial resistance, infection prevention, the rapid treatment of sepsis and deterioration. And these need to be considered at a policy level together rather than in silos. And on data, when many people listening hear about data, I suspect that what they're thinking about is data on pathogens, data on resistance genes among pathogens. It needs to be bigger than that. It needs to be patient focused. We need granular patient level data, including but not restricted to their blood tests, their vital signs, their demographic data, the process of care to them, and what's happened to them. And when we can start to link the data together, then we can start to link process and outcome, and we can start to be more intelligent about whom we're giving antimicrobials to, how urgently, and when. Matt also touched on the point about diagnostics, and this is critically important because the science around novel diagnostics and what we rather loosely call point of care diagnostics is astonishing. There are systems out there that are commercially available that can give us the results on a huge array of potential pathogens and their resistance genes within a matter of hours. But these are not integrated into clinical systems well. And we've heard about the acute respiratory hubs when this was changed, but in the space of bacterial infection, too often these rapid diagnostics sit many process steps away from the prescribing clinician. And that's why I think it's absolutely vital that we get those prescribing clinicians into the conversation. And then finally, on public awareness, I've mentioned Dame Sally. She has achieved almost certainly more than any human being on the planet in raising policy attention to the prospect of antimicrobial resistance. As an aside, I think if we look at the investment in the antimicrobial pipeline compared with the cancer research and cancer therapeutics pipeline and the cardiovascular therapeutics pipeline, we are absolutely not doing enough at a global level on this. But the public haven't heard the right message. The public have heard the message that you shared at the beginning, that we might not be able to safely give them a hip replacement when they're old. Our kids don't care about that message. They care about climate change and they care about plastics in the ocean for a couple of reasons. Firstly, it's tangible and we can see it. And secondly, there are simple actions that they can take to do it. Our public need to see AMR with a face. We need to hear from the people affected by it as well as the clinicians directly treating it. And our public need to know that this is affecting people in my intensive care unit right now and in every hospital around the country right now. This is not a problem for the future.
Thanks very much, Ron. Louise, could I get you to build on Ron's points in particular around diagnostics, I think, and the distance between diagnostics and prescribing clinicians and the real impact that has, and how that links to your thoughts on whether or not we've got the right approach to tackling AMR in the UK.
Yeah, thanks, Kate. Absolutely. I think it's a really important point to expand upon. Obviously, as a consultant microbiologist, it's my day-to-day. I'll start really by making the point which has already been very well alluded to, which is that in terms of antimicrobial prescribing, a lot of that prescribing is driven by clinician uncertainty. And where we can provide people with certainty is diagnostics. As Matt so eloquently put it, patients don't come with labels. When we first see them, we have to arrive at a diagnosis, and sometimes very, very rapidly. If we don't have the tools to make that diagnosis, we may end up not treating in exactly the right way or over-treating, because antibiotics in particular are seen as a low harm intervention because, as Ron has already pointed out, it's not visible. So getting the right diagnostics is a really important part of this process, and it is, sadly, I think, for bacteriology, something that hasn't really been focused on. We saw with the COVID pandemic how quickly rapid diagnostics could be rolled out for viral detection. Why can't we see the same thing with bacteriology? There are a few important steps for anyone who isn't a clinician to recognise in the diagnostic pathway. First of all, it's taking the right samples, requesting the right tests on those samples, and then crucially getting the samples to the laboratory. Once they're there, we need to have the right test to perform, and those results need to be available in a timely fashion so that they can be acted upon quickly. That also requires correct interpretation of those results in the clinical context. So a result on its own, a yes or no, it's not often that black or white. It's about the patient in front of you. And at the moment, there are a number of reasons why that process isn't working as it should do. So of course, having the right diagnostics are crucial. There is huge variation, and the Carter report a few years ago highlighted that beautifully. There is massive variation from department to department across the United Kingdom. The proposal there was centralisation of pathology services. And although there were a lot of very good reasons for that, actually, I don't think it's had the desired effect. Because one, there is still variation region to region. Two, labs were being asked to take on more work without the additional capacity to do so, and that includes access to the correct diagnostics. And rapid diagnostics are expensive. Most pathology labs have their budget, but the finances that they're allocated are allocated by the trust. So each department is going to have a different amount of money to spend on diagnostics, and it depends where you are as to whether you can convince people to spend money on the rapid diagnostics you need, and not just to buy them in, but to keep them up. It's reagents, it's maintenance, it's electricity, it's having staff to run those tests and interpret them. And throughout the NHS, no different in pathology, we have a workforce shortage, both in scientific staff, and I'll take this moment to also point out, in terms of infection specialists, this country is massively underrepresented in terms of infection specialists, given the burden of infection that we see. There are departments that are struggling to recruit microbiologists. District general hospitals don't have much access to infectious diseases specialists. And so clinicians on the ground are being asked to tackle increasingly complex infections without having the expertise to do it, or the contacts to be able to help them. So we've got a number of issues. It's capacity, it's access, it's workforce. We don't have the data to tell us what people are doing, what they're using, what they have access to, how they're using it. So to sum up, I would say the key things that we need are actually a national framework on what laboratory diagnostics for AMR should be. What should be the standard in every laboratory? How do we fund that? How do we make sure we have the infrastructure, including being able to get samples to a lab and perform a rapid test? Because with centralisation, you're often one lab, perhaps you've got one DGH miles away sending their samples to you. Well, it's no longer rapid if it doesn't get to you in a timely fashion. So we need to have a robust infrastructure, IT, data, support, workforce. It's something that now needs to be focused on from a national level, because an individual trust level is insufficient. It's not making a dent. It needs a national approach.
Thank you very much, Louise. And I think probably timely that the government and national bodies will be starting to review what the right approach is and what the next 5 years looks like when it comes to tackling AMR, given the action plan is coming to an end sort of next year. So this is all really, really valuable contribution about what they need to be thinking about, and I guess leads us quite well into my next question, really, which is around what more should we be doing, and what are the right levers to focus on to really drive improvement. So how do we help shape what the next 5 years of action around AMR looks like, and should it be more action around infection management as a much more kind of joined up approach? Matt, could I get you to kick us off on that one, please? What more should we be doing?
Yes, and I'm biased. I'm moved by what I've heard from the rest of the panel. What an amazing expert view we've had thus far. And we do absolutely need visibility of the scale of this problem, as Ron eloquently put earlier. And I'm also moved by what Louise said about infection specialists. If we look at the scale of infection in hospitals, in hospital care, but also in primary care, we see an increasing burden year on year of emergency admissions that come in with suspected infection. It now amounts, from an antibiotic perspective, to probably at least 40% of the intake. When you add in viruses, COVID, flu, RSV, you name it, we're well over the 50% mark. That's not even counting fungi or any other atypical organisms. So to have infection as probably greater than half of the total emergency caseload, probably responsible for 75 to 80% of total bed days, and the admission diagnosis in 2/3 of beds, and yet to not have a national program that focuses on infection management is, I think, a real gap. It's a gap that transcends, because of the example we set at big policy level, into every single local and regional organization as well. So how do you buck that trend and actually bring it together? Because a clinician seeing a patient has to take into account every single element of infection management every time they see a patient. And yet our policy levers, our drivers, and our leadership, our research, and our thinkers do not think along those lines. So we have a disconnect between the reality of frontline care compared to how everything else functions in terms of funding, leadership, research, organization, testing. I don't think we're ever going to have the luxury of having enough infection specialists. And I would argue that the role of the generalist is actually to become an infection specialist rather than develop thousands and thousands of infection specialists, because that is not going to happen in the current times. COVID has provided an opportunity for all of us to develop a skill and an aptitude for that. The campaigns that Ron successfully led for many years has invigorated the world around sepsis. But it's more than just sepsis. This is about everything to do with the general infection management elements. So we need to leap on that opportunity, not only within our general clinical population and non-clinical workforce across the NHS, but amongst the public as well. Because it's only through empowering them with tools of what to look out for and when to seek help and how urgently to seek help, through which that we can actually develop equal partnerships. And it's only through those equal partnerships that we're going to deliver on not only our aspirations for improved survival from severe infections, but also the mitigations of when you shouldn't be on antibiotics too. So a comms exercise across the entire organization, but a massive restructuring of the way we think about things, the way we deliver things, and the way we fund them.
Thank you, Matt. Ron, I think Matt probably talked about a few things there that I know linked to some of your initial comments around the importance of empowering people in whatever their role, whether they be a member of the public or a clinician, generalists as well as specialists. Could you build on Matt's points really around what more should we be doing, and what are the right levers to be focusing on?
Yes, of course. And so Matt talked earlier about pathways, and Louise has talked very eloquently around the inability of laboratories to embrace these novel and potentially hugely useful diagnostics. And I think a non-clinician listening would listen to this with horror, really, that we are unable to design pathways around infection management. And I must concede a sort of bias toward the term infection management, I proposed and conceived of the Infection Management Coalition, which is supported among other agencies by the ABPI. But when we're talking about infection management, we're talking about a pathways-based approach. We're talking about an holistic approach. We're talking about an approach such as that delivered for cancer services, such as that delivered for acute coronary syndrome. And the reality is we are, if we don't change things radically, never going to achieve that. We talk about silos. Silos is a very convenient and very fluffy, friendly term. What we actually mean is we've got to break down empires. We've got to change people's job descriptions. We've got to change the way the statutory bodies work together. We've got to bring in processes where we consider this at a policy level fully holistically, where we design systems to embrace, for example, novel diagnostics. We design systems to empower frontline prescribing clinicians to do the right thing at the right time. And as Louise has quite rightly said, we need the diagnostics and the interpretation of those diagnostics to do it. And, you know, perhaps it's slightly naive, but I think we need to stop thinking separately about national vaccination programs, antimicrobial strategies, sepsis strategies. We need to think about this all together. We need to break down those empires within the statutory bodies, get people together in a room with those patients, with those prescribing clinicians, and really shake this system up. Because if we don't do it, we are going to be failing not only our patients, but patients all around the world and potentially endanger mankind.
Thank you, Ron. I think some really important points there around bringing things together, breaking down existing nonsensical structures or approaches. Louise, is there anything more that you'd like to add to that around what more we've been doing and how we should be doing it?
So much has been said that I completely and utterly agree with, and to hear some of the things that Ron and Matt have been saying, it kind of makes my heart sing as one of those people who is day to day. I'm not a high-level policy maker. I'm not involved in these UK-wide decisions. I'm just doing my job day to day, and to hear people voicing things that I've thought myself is really pleasing, because this is becoming a crisis situation, and it feels a lot of the time as though the focus is on other things and AMR is acknowledged but not truly understood. And as has already been said, it's almost about redefining it. I think just saying AMR doesn't mean anything to anyone. This is really about the management of your mum, your dad, your children. It's making it much more personal. Of the things that I think we do need to do, I just want to really pick up on the point about training and education. So yes, we could absolutely do with more infection specialists, but we can say that about any number of other specialties as well. That's the state of the NHS at the moment. Generalists seem to be few and far between, because the thing is we're all becoming so super specialised. And that's where I'm going to draw in the medical legal side of things here. You start to feel less confident in your management if it's outside of your specialist area. And that's where there's an increased workload moving towards microbiologists and infectious diseases for things that clinicians should be able to deal with and feel confident with. But there is a lot of fear, there's a lot of anxiety. You can make a decision and you can be penalised for that decision, even though you made it appropriately at that time with the information that you had. So I think there's something in here about how our clinicians, our future clinicians, are trained, what they understand about antimicrobial resistance, what they understand about the diagnostics and how to interpret those, and about dealing with uncertainty. Because with infection, unfortunately, a lot of the time at the moment, there is uncertainty early on. So I think that's a really important thing, and for the public to understand that. And that's where it's really important, Matt and Ron have already said, about engaging the public in policy making. They are part of this as much as we are, and they need to understand some of the complexities.
Thank you, Louise. Colette, could I just get your thoughts on what more we should be doing? And I think in particular, the ABPI have obvious interactions with some of the national bodies, and we've heard around the different roles that they could be playing. But I guess be really interesting to hear, how do we set the approach that others can learn from globally as well?
Absolutely. Well, first I'd say I completely agree with what colleagues have said already. And I'd like to approach the answer really, Kate, in two parts: what the UK can do domestically and what we can do internationally, in addition to what colleagues have already identified. I think domestically, there's huge potential in recognising and promoting the role that vaccines, excuse me, can play in tackling AMR. Obviously, we know that vaccines can prevent commonly acquired bacterial infections, whose treatment would require antimicrobials, as well as preventing viral infections, which of course can lead to that spiral of from being mistakenly treated with antibiotics and contributing to misuse. But in the future, we may also have vaccines that can prevent patients acquiring bacterial infections in the first place in care settings. Sorry for the coping anyway. A recent review by Vaccines Europe found there are currently 15 vaccine candidates in industry pipelines that are targeting antibiotic-resistant bacteria on the WHO's priority pathogens list. Right now, vaccines, however, are not a full part of the AMR policy narrative, and our vaccines assessment process isn't really able to consider the AMR impact of vaccination programs or ready to deal with potential targeted AMR vaccines. So that's one issue. Another, which Louise has already talked about, is of course diagnostics. And of course, I'm not going to repeat what Louise has already said, but I do want to reinforce that a key lever that we have to deliver progress here is by including vaccines and diagnostics in the next iteration of the National Action Plan in AMR. So that's the domestic piece. Globally, I've already said we need other countries to be doing their own work to support the development of new antimicrobials and sharing approaches. The next big opportunity that we have to gain that commitment will be the UN high-level meeting on AMR in September of next year. And we will certainly be working to reinforce that this is a moment for the UK government to go out there and get AMR back at top of political agendas. The government needs to be working with industry to understand the key and align on the key learnings from the UK's new model and share those learnings with other countries to support the development of their own approaches. So we really just can't underestimate how important it is that industry is part of that dialogue as well, because of course, if the model doesn't work for international investors and innovators, then it won't work at all. So that's very much an industry perspective, in addition to what colleagues have said already.
Thank you very much, Colette, and it's great to have a real range of different perspectives here from all different angles, so really valuable contributions. I'm going to move us on now to our live audience Q&A. So I think hopefully those listening have been dropping questions into the Slido chat and upvoting other questions as well. So the first question that I'd like to put to the panel, please, is enough emphasis being given to infection prevention / public education? So I think that's probably tied into some of what we've touched on already, but Ron, I'll come to you, please, on that question.
Well, I can take the public education side of the question probably better than I can the infection prevention side, but they are related. And this is in the context of our raising public awareness around sepsis. So we have some experience. I think what we've developed so far, or what's been delivered so far, has been education that's accessible to the Guardian reader, for example. What we haven't had is public awareness, public education that's accessible to the tabloid reader, that's accessible to the school child. And I've already mentioned plastics in the ocean. That's really sticky with our school children because there are things that they can do. They can nag their parents to use recycling properly.
I think we might have lost Ron there. I'm sure he will be back in a moment, and I think his point is well made around what appeals to the public and all different ages in the public and the future of our generation. Ron, I think you're back with us.
Sorry, yes, I think I am back. So what we need to do is to really make this accessible to all. We've heard that there are discrepancies in the frequency of resistance between our populations. And we heard at a King's Fund meeting a couple of weeks ago from a microbiologist from Leicester who found that In areas of highest socioeconomic deprivation, the resistance of E. coli to beta-lactam antibiotics was 40%, whereas those more affluent areas, it was half that, it was 20%. So we need to be culturally and context sensitive with our messaging. We need to deliver messaging that empowers the public to take small steps of action. And that will include educating them that it's not okay to seek antibiotics when you've got a common cold or you've got the flu and you want to return to work next week. To teach them that actually it is okay, if they're worried about a loved one who's seriously unwell with an infection, to ask what the diagnostics situation is, to ask whether they've found the pathogen. We need to get our health professionals to tell patients when they've been infected with a resistant bug, because we're frankly appalling at that at the moment. It's very difficult for us to find case studies for the media who are aware that they've been affected by these resistance bugs. And of those 58,000 people mentioned at the beginning, I suspect that only about 8,000 have any knowledge that they had a resistant bug affecting their inpatient stay. But we need to give further direct action, and healthy lifestyle has to be a part of it. Responsible meat consumption and other produce consumption also has to be a part of it. And we need to ensure that the food chain is as free of antimicrobials as it possibly can be, including for people on lower incomes. And if we only address the human health side of this, then once again, we are failing our public.
Thank you, Ron. Louise, I'm just going to come to you to see if there is anything further you would like to add on the inequalities angle that Ron highlights there, and how stark some of those differences are in who is experiencing these infections.
Yes, thanks, Kate. It's stark reading the SBAR report where that data came from, and it actually was in the SBAR report last year as well. As an area where we have, in the Northwest, certainly we do have areas of deprivation, and we also see high AMR. This is something that I think we've been aware of for some time, and there are multiple factors that are involved with that. Things like health-seeking behaviours within groups, also living conditions. In areas where you maybe have large families all crammed together in very small housing, where perhaps they don't have good water supplies, electricity supplies, etc. We've seen that within those patient groups, the health is poor, they're open to infection, they develop infections. And there is something in that, isn't there, as Ron was saying, about teaching people to look after their health. We focus on things like cancer, we focus on things like smoking and the implications of smoking. We never talk about the effect that these things can have in terms of infection, how it makes you more open to infection, how you are therefore more vulnerable to developing infections with antibiotic resistant organisms, because every time you're treated, every time you have that antibiotic exposure, you're increasing your risk. So for those whose health, for various reasons, deprivation is one of a big one that we do need to tackle. But for those individuals, their health, in any decline in their health, their higher risk for developing chronic disease through smoking, for example, means they've got a higher risk of developing those infections, means they're at higher risk of developing antimicrobial resistant infections. So it all ties in, that public health approach, it all ties in, but AMR is often left out of that conversation, and it needs to be part of it. And I think one of the ways that we can do that from an education point of view would be at schools. I know I've got some friends with children, they're taught about plastics, they're taught about climate change. Well, let's teach them about antimicrobial resistance, let's teach them about infection and how to make ourselves healthier, how to keep healthy, how to avoid becoming unwell and leading to those repercussions in the future.
Thank you, Louise. And really hearing elements of the sort of One Health approach that I know the World Health Organization certainly champions around tackling AMR, and it not just being through sort of the treatment side of things, and there being so many other angles to this. I'm going to move us to our next question from the audience, which is around diagnostics and testing. So the question is it realistic to test every patient before an antimicrobial is prescribed? CRP or PCT testing is used routinely in other countries, but why not in the UK? So I'm going to put that to Matt, please.
I think it's a good question, and I'm not sure it entirely is. It's just a binary answer. Certainly, if we look at the majority of infections that arise, 90%, maybe even higher, are treated in the community where there is not that availability, certainly in a general practice setting, a district nurse encounter, or indeed a care home assessment. However, those sorts of tests can help, definitely, in the right context. But I'm not sure about a blanket usage of them. Any test has to come with a question, and any test has to come with a response or a response to the test result that will lead to an improvement in the management of the patient. Tests are not cheap. And it's not just about the cost of the test itself, but the cost of the update, the resourcing of the machines, certainly from a point of care perspective, as well as the time delay. In most healthcare settings now, time is one of our biggest pressures. So the concept of a point of care test only really comes to light, I think, when it can be done within a 10 or 15 minute window. And any longer than that, you lose a lot of interest and I suspect impact. So I know CRP and procalcitonin both come in those flavors, but there's an economy of scale question. If you are making that available in every single hospital, that's one thing. If you're making it available in every single GP surgery, that's a whole level of exponential extra cost and potential delays to decision-making. There are cases when a point of care test can massively influence the change in management of a patient. And if we reflect back on last winter's deaths from group A strep in children, where a lot presented with viral type presentations, presentations that you would probably not give an antibiotic to. And this brings in thorny questions about, have we got our group A strep swabbing protocol correct in terms of that management? Will it help us in due course? Where is the research? Where is the evaluation? Where is the evidence? How aggressively can we find the answers to those questions? And how can we safeguard a population in the light of sometimes a dichotomy between the evidenced published guidance and pathways and what you actually see in clinical reality, and when you're faced with that worried parent in a waiting room? So I don't think there is a clear answer yet, because we haven't got enough data and peer-reviewed evidence. But I think my answer would be we could do more. We could go faster towards this, and we could actually get our answer better if we did some more at-scale infection assessments, particularly in community assessment areas. I think the answers to this lie in the community and not the hospital.
Thank you very much, Matt. Louise, I don't know if there's anything you wanted to just add to that one, given.
Yeah, I think I just hark back to something I said earlier, which is about interpretation. I think biomarkers have their place, certainly, but they don't tell the whole story. There can be lags in changes in the biomarkers. One of the things that I constantly try to impress upon the clinicians that I work with is diagnosis is obviously it's a bundle approach. You cannot rely on one single test to give you the answer. And I worry sometimes that increasingly, though I'm a microbiologist, I love a diagnostic, but increasingly maybe we do focus too much on what the machine says and not the patient, because actually you see so much just from looking at the patient. In the hospital, for example, which is where I'm based, I don't do a lot of community work, but in the hospital, I see people escalating antibiotics on the basis of a CRP rise, one CRP rise. The patient looks fine, but the antibiotics have been escalated because the CRP isn't coming down as they expect it to. So there's a bit about interpretation, and again, I'm going to harp on about education, understanding the limitations of your test so that you can interpret them in the correct clinical context, rather than taking the view that one test is going to give you the answer. And I think in a world where people are so busy now, the hospitals, the GPs, they're under pressure. They need to make decisions very quickly. It's very easy just to look at a test and say, okay, right, the CRP is up. I'm going to start some antibiotics, even though there might be another reason for that. So diagnostics are important. It's not feasible, I don't think, to use a diagnostic to diagnose every single infection before you start antibiotics. But I think there are cases where we can use it. And that's really where the national approach comes in, isn't it? To say, well, what have we got? What can we do? And how can we build those pathways that Ron and Matt have already spoken about?
Thank you, Louise. And a key area that has come up in a number of the questions on here now is around remote prescribing and how that fits into these different pathways as well. And so, Ron, if I could get your thoughts on kind of the implications of remote prescribing in this, that would be brilliant, please.
Well, I can offer my prejudice, certainly. So, we've got to ensure that our NHS becomes once again resilient, becomes once again accessible. Absolutely. Many of us see the value of remote consultation. There are some fairly robust and not fully, but increasingly evidence-based approaches to telephone triage, to video consultation triage, and those are important. But to be honest, the thought of remote prescribing becoming a norm, as someone who exists in the luxury of a very well-staffed, very well-resourced intensive care unit, it horrifies me. And I'll give an example as a narrative, particularly for the non-clinical listeners. A friend of mine brought their baby in to this hospital last night. They won't mind me sharing, and it is a good friend of mine, and I'm not going to break any confidence. But they phoned me this morning and said they're about to discharge my baby, who'd come in with a temperature of 40 degrees Celsius, and then it had dropped to 35 degrees Celsius, which is quite alarming normally. And they said they've done a CRP test and the result's 170, which for non-clinicians is a fairly moderately high CRP test, something that we would certainly see with bacterial infection and less commonly see with a purely viral infection. But this child was smiling at me, was alert, was looking around the room, was warm to the touch, looked a well child. And I said, look, you've got my phone number. I think it is safe that they're sending your baby home, but if you're worried, give me a call. And that baby went home without antibiotics. I don't think we can replace the consultation process, the physical assessment of a person anytime soon, unless we do it with very sophisticated integration of technology. I think if we were to move, for example, the NHS pathway system that underpins 111 from a very binary list of questions to a more Bayesian and intelligent approach, then we'd be starting to move in the right direction. Totally agree with Matt and Louise that diagnostics per se are not the only solution, but this needs an integrated system-wide approach if we are to safely deliver remote prescribing at any scale whatsoever.
Thank you, Ron. Matt, is there anything you'd like to add on the role of remote prescribing and how that plays into this?
No, I fully agree. And the recent NICE guidance supports that view, where remote consultations are not recommended in community settings for that reason. We also know from good evidence that remote prescribing increases the likelihood of an antibiotic being prescribed, often for the wrong reasons. From quite a few peer-reviewed publications recently, and that the proportionality of suspected infection prescribing during COVID increased when remote assessments were undertaken. Again, 3 bits of large-scale evidence that point to why remote is not the right way forward. We have to add to the conversation, and to add balance to that conversation, the fact that patients are going to be acquiring point-of-care tests from Amazon and Tesco's and Sainsbury's with increasing metronomic frequency. This is going to only increase over time, and it wouldn't surprise me soon to see patients phoning up their GP surgery with a C-reactive protein result, or indeed a group A strep result. Now, this is where we get into sticky wickets and difficult problems. What do you do as a clinician, a very busy clinician in primary care, for instance, when you are phoned by a very well-informed patient with a CRP, a group A strep result, a potential flu result, a COVID test result. How do you react to that? How do you respond to a patient with an unqualified and unquantified test, which we don't know the sensitivity or specificity for, but nonetheless is telling you a result with some symptoms that might be consistent with an infection? Do you treat over the phone? Do you cover yourself? Because if this patient then goes on to die from sepsis, who picks up the bill? Who picks up the blame? So there is a pressing need essentially for, I think, very important, urgent guidance to support clinicians and the system as a whole in the face of more, I guess, of this remote assessment process and the empowerment that patients now have regarding their ability to do their own tests at home and then inform the healthcare service once they get the results. And if we don't get that bit right, then I think we're going to be heading for real trouble later on down the road.
Thank you very much, Matt. Okay, I think really valuable discussion around some of our audience questions, which I think will help us sort of start to wrap up some final thoughts really around what good looks like and how do we get there and how will we know when we are there. So Colette, could I ask you to kick us off with what you think good looks like and how we're going to get there?
Yeah, sure, Kate, and I'll be brief because it's been fascinating to hear from expert colleagues. And I completely agree that, as they have said, integration and coordination of efforts and expertise is key, underpinned by good data. I'm really pleased to hear you and Ron referencing the One Health approach. Breaking down Empire's desperately needs to involve DEFRA as well as the Department of Health. We are still seeing prophylactic antibiotic use in sheep and cattle, which is frankly appalling, and a lot more needs to be done there. I think in general, we need to be open to constantly challenging, review our own work and see if it's actually delivering as intended. I mentioned for the ABPI, obviously the big focus is making sure the new model is rolled out, but it actually does incentivize the development of new antimicrobials, and the companies are able to use it, that it makes a difference to R&D decisions, and patients in the NHS are actually benefiting at the other end from new antimicrobials. So that constant review and challenge as part of an integrated community is key. And we need to have transparency and accountability for the delivery plans. We've all talked about the forthcoming updated National AMR Action Plan, and we need to see that clearly set out responsibilities for the commitments in it, delivery mechanisms and monitoring so that everyone can see the progress that's being made and help keep us on track. Finally, how do we know when we get there? It's probably the toughest one to answer, but it's obviously when we're living in a world where fewer people have to die from antibiotic-resistant infections.
Thanks, Colette. I think you're absolutely right. It's when we start seeing some of those trends going in the right direction rather than remaining rather steady or, in fact, going in the wrong direction. Ron, is there anything else you would like to add to what Colette has already helpfully summed up as kind of what good looks like and how we get there?
So, I mean, I'd sort of segregate this into what good looks like for me at a national level in terms of public awareness and my charity roles, compared with what good looks like at an individual clinician level. And taking the latter first, what good looks like to me, again, I'll illustrate with an example. NICE recommends that if someone's admitted with pneumonia, we give 2 antibiotics. Now, in someone who's got a normal immune system, the second antibiotic is really there just for Legionnaire's disease. And it takes me typically 2 or 3 days to get my Legionella antigen result back. So, you know, at very basic low level, good for me means I get the information I need at the time it should be available to me, which is within a couple of hours at most, so that I can avoid giving antibiotics to many patients that I know aren't going to benefit from that individual agent, but there's guidance suggesting I should do it. At a national level, there's so much. It's when AMR, in the context of sepsis, severe infection, and harm from infection, is a public topic of conversation, as central as climate change, as central at a public and policy level as plastics in the ocean, reducing emissions, and so forth. And when we see investment in saving lives from infection which at a global level claims more lives than cancer. And I think many people don't realize that infection is responsible for 1 in 5 deaths worldwide, that we see international investment in improving outcomes from infection that is at the same level as investment in cardiovascular disease and cancer.
Thank you, Ron. What a important note to end on around the kind of the status that AMR and infection management needs to have for everybody involved in this whole agenda. So thank you all for the wealth of expertise you have brought to our panel discussion today. Really meaningful discussion. I'm sure will not be the end of our conversations about AMR at the King's Fund. And for everybody listening, really encourage you to share the link with your colleagues, and they can register to watch on demand. Thank you for your questions. Thank you for your thoughts. And please feel free to leave any feedback as well. There'll be a survey emailed to you. And finally, thank you again to our event sponsor, the ABPI, for supporting such a meaningful conversation this afternoon. Thank you.